The doctors check the pulse of heart disease, starting now on call. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
LARSON Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by DAKOTA Care, the Brookings Health System, Dr. Mark Bubach with DAKOTA Allergy and Asthma, DAKOTA Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. About 600,000 people die of heart disease in the United States every year. That's 1 in every 4 deaths. It costs us nearly $110 billion annually. We check the pulse on heart disease when the doctors are on call tonight.
Hello and welcome to On Call Television. The heart sets our rhythm of life. It's the hardest working pump in the world. It beats an average of 70 times each minute, adding up to over 36 million pumps each year. The heart pumps oxygen-rich blood from the lungs to the body and pulls it back again to start the cycle over. And when we fall in love, we feel it in our hearts. We get Twitter-petted at the sight of our spouse and our heart rate goes up, and when we lose a parent or other loved one, we feel our hearts sink. This up and down rhythm paces us throughout our lives, but sometimes the rhythm is disrupted. Our valves can wear out, our coronary arteries can get blocked with plaque buildup, our heart can get out of rhythm. Tonight we're going to talk about the heart that goes lub-dub, and with us to answer your questions are 2 fellows of the American College of Cardiologists, Dr. Riyad Mohama and Dr. Michael Hibbard, both from North Central Heart in Sioux Falls. So let's start with you, Michael. Where's your home, Mike?
Well, I'm from Sioux Falls now. We moved here from Minnesota. I started out farming before I got into medicine, so it was a long way around the bend. Our family raised registered quarter horses, and the farmland was too expensive and I couldn't afford to go and do it, so I decided to go to medical school instead. So a long ways around to get to be a heart doc. Yeah,
and in what smaller town community are you from originally?
Alexandria, Minnesota.
Oh,
up the
there.
Lakes up by, not Alexandria, South Dakota now, Alexandria, Minnesota.
Minnesota. So
right.
Up near where the lots of lakes and trees?
A ton of lakes. My grandfather was a cattle jockey up there, and we sold cows to all the people around the lakes and fished there a fair amount and broke all the horses for the dude ranches for city kids to come up and ride horseback.
Yeah. And where did you go to med school?
Just about everywhere. I went to the University of Minnesota and then Mayo Clinic and then back to the University of Minnesota again.
Did your fellowship at the University of Minnesota in Minneapolis?
The fellowship was at Mayo Clinic, Rochester.
Oh, okay. All right. And then you came to North Central Heart at what time?
1992.
Just a few years ago.
Yeah.
And Riyad, you're originally from where?
Syria.
Syria. So you're watching the news right now.
Indeed, yeah.
So pretty tragic time over there.
With sadness indeed. That's very bad news.
You have family?
Yes, we still have family and friends, a lot of friends.
All right. But where did you go to medical school?
Well, I went there at the University of Damascus in Syria. I finished there and then came to the United States. Did initial training, residency at Georgetown University, and then finished my cardiology in New Jersey and went on to subspecialty in electrophysiology, which is dealing with heart rhythm problems in Canada, University of British Columbia.
Oh, and you've been at North Central Heart for longer than
Almost,
Hibbard.
almost, yeah, 2 years longer than Mike, and we enjoyed that whole working there for that period of time. It looks like almost yesterday.
Yeah, wasn't it just a minute ago? Well, all I can tell you is that the two of you, I wanted to tell you thank you for all of the care you've provided for my patients for many years. I've sent a jillion in your direction, and you send them back patched up and fixed up and electric wired for the future, and many more people too. This state and region appreciates you. Thanks so much for doing that.
bet.
And thanks for being on our show tonight. Tonight, we're going to be talking about all things heart, but probably more having to do with the rhythm of the heart. And we need your questions. We need your heartfelt questions. So why don't you give us a call at 1-888-376-6225, 1-888-376-6225. We need your questions. This is your show. And there are bunches of things that you could talk to us about or ask us about, but I'd start the question about the rhythm. What was it that triggered you to go into heart rhythm specialty, EP, electrophysiology, the heart rhythm specialty, Riyad?
Well, EP is relatively a new field. I mean, it's not in terms of, we have been dealing with cardiology issues for the past 100 years. The electrophysiology field has developed in about 25 years ago, mainly when the treatment of rhythm became possible with a procedure called catheter ablation, where you can go inside the heart, look at the focus that's causing that disturbed rhythm, and cauterize it, ablate it, kind of cure it, if you will.
But I would think the pacemaker was the one the pacemaker was the thing that brought your business, but it was the ablation?
Well, ablation and pacemakers and defibrillators, for that matter, too, are all part of what we do. Now, disturbed rhythm is almost in the majority of cardiac patients. So previously it used to be just medications that we use, and we still use medications, but now at least we have in our possession a lot of instruments and tools and techniques that we can do to help cure these problems or alleviate it or make quality of life much better.
Right. So, Mike, so you take 60-year-old people and older. You see a lot of different kinds of heart diseases. What kind of heart diseases do you see in that 60-year-old and older group? And how many of them are heart rhythm problems?
Well, I would say a very common problem is atrial fibrillation. 15% of the population is going to get that if you live to be old enough, into your 80s. What I tell people, a lot of people have a hard time with these rhythms. There's complicated business, but basically, when I talk to people about atrial fibrillation, I tell them that their heart runs like an old John Deere instead of an International. And so it's puckada, 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 irregular, and a lot of people notice that, but they're spooked by it, they're afraid from it. But when they find out how many people have it and there are so many solutions for the problem, it tends to calm them down.
You know, a lot of people will have extra beats here and there. I mean, I know that when they first looked at Holter monitors, which was measuring your heart rhythm 24 hours and looking at that 24-hour strip, they did med students as their standard, and they found that, oh my goodness, there's all these dysrhythmias we had thought were only in these very sick people. A lot of people will have an extra beat here and there, sometimes pretty frequently, every third or fourth beat for a while when they have too much coffee or whatever it might be. But what you're thinking more about is this thing called atrial fib. Tell us more about that.
Well, what you were saying just a minute ago is almost everybody's heartbeat skips once in a while. And when you think about it, if I was the one who swatted you on the fanny when you came from the birth canal and said, go in the corner and clap your hands 100,000 times a day for 65 or 70 years, don't take a break, Christmas, Easter, New Year's, Hanukkah, Ramadan, Thanksgiving, 55 below wind chills in South Dakota, that you would be clapping your elbows by the time you get to be 70. And it's amazing. And so even if I was going to give you $10,000 to clap your hands in a regular rhythm 100,000 times today over till tomorrow, do you think you would collect my money?
No, I wouldn't.
No, it's impossible. So it's very common to have some skipping. The thing is it skipping you need to worry about or skipping you don't need to worry about? And that's where Dr. Mohama comes in.
Right. And so how often So if you say that most people have these skip beats, and he said 15% of people sometime in their lives are going to have atrial fib. What other rhythms would we worry about? And then let's get back to atrial fib. But you know what? We need to go to this first. The American Heart Association recommends 40 minutes of moderate and vigorous aerobic exercise 3 to 4 times each week. Hard-working Midwestern farmers get this kind of exercise daily and in all types of weather. But exercise and maintaining a healthy weight isn't always enough to stave off heart disease.
This fall I went deer hunting with a friend about 200 miles away, and I had trouble both day and night there, and it kind of scared me and scared the friend I was with. When I got back from deer hunting, I didn't have any more problems, and mentioned it to Dr. Holm when I went for his appointment, and he thought it might be acid reflux, but from what I told him, he thought we should schedule a stress test. And about 2 minutes into the stress test, I could start to feel a little bit of pain in my chest. And I told him, but it was not as severe as when I'd been hunting. And when I stepped off the treadmill, he put a nitro patch on me and says, "You have 2 choices." He said, "You can call somebody and go to the heart hospital in Sioux Falls, or I will call an ambulance." 3 hours later, I had an angiogram at the heart hospital in Sioux Falls, and he informed me at that time I had heart blockage and I was not a candidate for a stent. So he says, "I'm scheduling you for open heart surgery for the next available operating room," which was about 24 hours later. I had had 3 bypasses at that time. So I was in the hospital for 6 days, and then it was kind of during the Christmas holiday, so it took a little while before they got started back here in Brookings for the rehab. So during the rehab, they do about 10 minutes of a treadmill and 10 minutes of a new step and 10 minutes of a recumbent bike with a rest in between. They like to get your heart rate up for a period of about 10 minutes per time. So, looking back, I have had probably over a year ago, I had some problems. Didn't really think that it was much. I kind of passed it off as, not being in shape. I had some, when I would walk or something, you'd feel it once in a while. The doctor asked about history, and I tried to think back, and there's a possibility way back on my mother's side there might have been, but not really, not immediate. There is not a history for me. So, people have asked me if I feel better than I have felt for a number of years. And so far with the rehab and stuff, that I can't really say that yet because my chest is still tender, and there's some of that healing going on. But the one benefit I noticed immediately was breathing. I could breathe easier the next day in the hospital, and I really did not realize that I was not breathing before, or was having difficulty with the breathing before. I would say to watch the diet a little bit, read what is good and bad for you, and I guess what I would say is, in my case, don't ignore the small symptoms. I mean, as I look back at what I had, there was some of those that the pain was fairly severe, and I kind of passed it off as just being out of shape, and really it was, as looking back, it was more serious than I gave it credit for.
I really appreciate his willingness to come to the camera and tell his story. And, it wasn't the perfect story for angina. I mean, that's why classically, if it's a classic angina, you really don't even need to do the treadmill. I just send them to you, you do the angiogram. This guy didn't quite have the perfect story. Let's see what happens. And those ST segments went down.
I think that this is a great point that you're making, Rick, is that what I refer to as the Hollywood heart attack, where the guy grabs his chest and he sweats and he's looking ashen and gray, happens only about 5% of the time. And what this fellow really said is that he noticed that he was modulating down, couldn't do as much, and he just assumed that's because of getting older. And that is not supposed to be that way.
Right, that's right. So thank you for doing that, Loren. Join our conversation by calling in your questions at 1-888-376-6225 or send us an email at questions@oncalltelevision.com. We'd appreciate your input, your questions. Your questions can be about heart rhythm, but it can be about anything we want about the heart. We're pointing at anything on the heart. And actually, we've got some questions. One question had to do with, and this is what we were talking about before, discuss the current treatment of atrial fib. Riyad, let's just talk, what is atrial fib, and explain it. In fact, why don't we do that, video that we have. What is atrial fib, Riyad?
Well, atrial fibrillation is an irregular rhythm at the top chambers of the heart. The heart, as you know, has two top chambers, two lower ones, and we believe nowadays that it is coming from specifically some veins that pour into the top left side of the heart, called the left atrium. And atrial fibrillation is very common.
The left atrium, not the right atrium.
Well, the right atrium, it does come from there, but probably in about 5 to 10% of the time. Atrial flutter, which is a cousin to atrial fibrillation, does seem to happen more often on the right side in the right atrium.
All right. And as you saw in that illustration, there was an electrical charge that started at the top, went to the middle of the heart, and then it spread out through the heart, the Purkinje system or the conduction system. Now, atrial fib is this irregular heart. So if I'm a normal guy and I flip into atrial fib, my normal heart rate at 70, what will my heart rate then turn?
Well, initially, if that is the first time atrial fibrillation happens, atrial fibrillation means that the top part of the heart is beating at about almost 400 beats per minute. Now, in our hearts, we have a kind of a normal or natural brake system that would not allow that 400 beats to go down
Which
all the
would
way
kill
to
us.
lower, which would kill us. We don't tolerate that. So we have that natural brake system that will make it slower. But even slower at about 150 or even 200 beats per minute, we would not be able to tolerate it. So that's what atrial fibrillation can cause. It can cause our hearts to go fast that much. But with treatments, with medications and what have you, we can slow it down to a tolerable level.
Right. Now, one of the major problems with atrial fib is that the atria are just quivering, and so they're not emptying, so there's a risk of blood clots. So what do we generally do with that?
Well, indeed, that's one of the issues that come with atrial fibrillation. One of them is the risk of clot, and that's an important one. There are specific individuals or risk factors that we think can make you at higher risk for having these clots that eventually might cause stroke or go anywhere else in your body. So these would be high blood pressure, having diabetes, age older than 75, having congestive heart failure, or any kind of vascular disease. Those can make your risk for clots and stroke higher than normal.
So as that risk goes up, we put them on blood thinners.
That's correct.
And there's a debate about different kinds of blood thinners. You want to say in one sentence what's your take on warfarin versus the new agents?
Well, at this point, actually, I'm giving my patients the preference to what they prefer to take. Warfarin is an old one. This year we celebrated its use for 70 years. So it has been around for a long time. Everybody calls it the poison, the rat poison.
Right.
So, but it has a lot of benefits and helped a lot of patients over the years avoid strokes. You have to check your blood frequently to make sure that you are within the range that will make it therapeutic and beneficial. The newer ones, you don't have to check that blood work. You just take a pill or two every day on a regular basis, and as long as you take your pills on time, your blood will be thinned enough, and studies have shown that it will prevent that clotting and stroke risk.
And so it's a come see, come saw. I'm one of the old school, I'd like to monitor that they're taking this drug and know exactly how well it's working on them. And it's even with the cost of monitoring, it's 4 times cheaper than the other version. But there's all sorts of that. We can talk about atrial fib more, but you know what? We're getting wonderful questions, and we want to jump into it. Mike, any further comments about atrial fib?
Well, the thing is with these newer agents is a fiscal one, and most people are trying to make ends meet just to buy their pills, and a lot of people that have atrial fibrillation have a variety of other conditions, and they have several other medications to take as well. And so when you consider the age that you are, you have to figure out how much is that going to cost me over my lifetime. And in that case, I have many patients who can afford the convenience, then they want to take these newer agents, but for a lot of people, it's just financially out of the question.
Right, so it can be a financial issue. Well, and it's early, you know, they're new drugs. I'm happy that they're developing new drugs, and I'm not against them, but I'm just kind of an old conservative guy, and there's a place. And I know you're using all of them, aren't you?
That's correct.
Let's just roll in questions and then pretty quick answers, okay? Sioux Falls, please discuss current treatment, well, atrial fib. 73 years of age, regular heart rate of 44. Is that cause for concern? Riyad.
44, if you have no other symptoms, you don't get dizzy spells or you pass out from this,
Don't worry about it.
don't worry about it, especially if you're an athlete or you do some exercising, 40 beats per minute in regular rhythm should be just fine.
If you are having symptoms and you're on a drug that slows your heart rate, Mike?
If you are having symptoms and you're on a drug that's slowing your heart rate, then check with your doctor, because there's plenty of problems that happen from medications, and we certainly don't want to be causing any trying to make somebody better.
But you don't want to stop them on your own. Here's a question from Sioux Falls. What are heart palpitations? What causes them? Does it damage the heart? How can she fix it? Riyad.
It depends on what the palpitation is. Palpitation is the sensation of having a fast heart beating or irregular beating. So the first step will be to diagnose this, find out what it is. A monitor of some sort, either 24 hours or for a month, that will show us what the nature of this. And then based on that, we can base treatment.
Yeah, you got to know what it is. Pipestone, Minnesota, a caller has been told she should have heart surgery because her heart backwashes. She doesn't take any medicines. Is there anything that can be done other than surgery? So backwashes, Mike, I'm going to take this picture that we have and go back to heart valves. I'm figuring it's probably a mitral regurg or aortic regurg. What do you think?
That's what it sounds like. The deal is that the way I explained it in the old cistern days when they used to pump the well up, if you're making a stroke and getting the full benefit of each stroke, that's the way a valve is supposed to work. But if you think of it like there's always water running back down the well, then the heart's got to do double the work for every stroke, and you're pumping like this, and that's what your heart needs.
You're pumping the double. So show us what valves might be going on.
The mitral valve is this valve right here, and we're looking at the side of the heart as we cut it like a football and looked up from the end. This valve is probably the most commonly studied valve in cardiology and one most frequently that has problems. There's a wide variety of solutions to that, and not always does it end up with surgery. But you have to remember, even a little bit of inefficiency, if it's 100,000 times a day is what your heart pumps, it pumps 2,000 gallons of blood every day, and even if a little bit of leakage over your lifetime, that can cause an incredible amount of problems. The heart is able to compensate up to a point, but if it leaks more than, say, 20 or 30%, it starts to have a cumulative effect, and you have to very carefully monitor that. Even if you decide not to do surgery, it has to be monitored very carefully, because if you wait too long, you can have permanent damage that you can't reverse.
I mean, and this is the other one that people have problems. So the mitral's the big one, but the aortic is the other leaky area, and we like to think that this can be repaired and this can be repaired, but the time is one of those.
Timing is crucial.
And so if a person has a significant, severe mitral regurg, mitral valve leak, when do you repair it?
That's a very complicated and controversial question. What you really need to do is seek out somebody who knows what they're talking about in terms of managing that. And a lot of times people have their own ideas. They're afraid about surgery and they're afraid about all these complicated operations. I just got back from Arizona at a heart meeting there. 1,000 physicians from all across the country were in a room arguing and arm wrestling about what is the right strategy. And you're talking about things that are pretty significant, like heart surgery and then taking blood thinner maybe the rest of your life. So by all means, if it can be repaired, that would be the first strategy if you do need surgery.
And so your answer was this is an individual deal, and then you have to decide whether this valve is replaced with a plastic or mechanical valve, or whether it's replaced with a pig or a cow valve.
Usually if you're determining between a pig valve or a so-called tissue valve or a mechanical valve, The older or the younger you are, the more likely you're going to have a mechanical valve because of durability. The tissue valve statistically will have about a 10 or 15% failure rate within 10 years. So that's not the valve you want to get if you're 50 years old.
Yeah. The heart has 4 valves. These valves work together to pull oxygen-rich blood in from the lungs, push it out to the body, and make sure blood doesn't flow back into the heart when it's not supposed to. But sometimes the valves lose their ability to close properly and need to be replaced.
Patients are in good hands during heart surgery. They have a team of specialists, including their surgeon, monitoring them at all times.
The anesthesia team, the heart-lung perfusionist, 2 nurses, 1 surgical technician, and then a circulating nurse as well.
Before the surgery, the patient is given anesthetic and their body is disinfected. An echocardiogram is performed to give the surgeon a clear look at the amount of damage to the valves before surgery. This patient will need a replacement of the mitral and aortic valves. The surgeon cuts through the breastbone and the patient is put on a special machine that keeps oxygen-rich blood flowing throughout the body while the heart isn't pumping.
The heart and body is supported on a heart-lung machine, which is a series of tubings that connect to a machine that really serves as the heart and the lung.
Next, the heart is cooled and stopped, so incisions can be made in the appropriate places for the valves to be replaced. The diseased valve is cut away and the surgeon measures the valve for a replacement piece. A biological replacement valve will be used in this patient.
The one that we'll use is a pig valve that has been specially processed, then mounted on a sewing type ring that allows us to hook that into the heart.
Mechanical valves made of pyrolytic carbon and stainless steel are also an option in valve replacement.
So they can last a lifetime, but you have to be on the blood thinner. And that's the downside, because anybody on blood thinners has a certain, even though it's small, a certain risk each year of some abnormal bleeding consequence, plus the nuisance of the pill a day and the blood test a month.
The aortic and mitral valves are carefully stitched into place one at a time. Valve replacement surgery takes about 4 to 5 hours to complete, and the patient will remain in the hospital for about a week.
In an uneventful recovery, somewhere in the 5 to 7 or 8 day range. Obviously, it's patient dependent, age dependent, and in some respects, the magnitude of the surgery that's done.
And that graphic, which was, was in invisible ink, if you could really have read it, it said 99,000 valve replacements a year. The history of doing valve replacements is very important, and most of the time we do it on the right side because that's the powerhouse. The left side receives it from the body, pushes it to the lung. I'm sorry, the right side takes it from the body, pushes it to the lung. The left heart is the one that pushes it past the mitral valve and then past the aortic valve, and that's why those are the majority of the valves, but that's not always correct, is that, Mike?
The vast majority of valve replacement is done in the aortic and the mitral position, which are the valve that was getting replaced there was the aortic valve, which is the main pipe that sends the blood out to the body. The mitral valve takes the blood, the oxygen-rich blood from the lungs back to the heart to be circulated for the body. If the mitral valve leaks, that shortness of breath is usually the symptom that you get. You can get shortness of breath from the aortic valve, but the compensation for the two is completely different. And if you have problems with both valves, that really complicates the picture because the changes that need to take place in the heart to compensate for the one are completely the opposite of the changes that need to take place for the other.
So the only other question, and we've got a ton of questions, so we need to get to them, answer them quickly, but aortic valve happens to get calcified a lot more as we age, and I see it because we've got such an aging population. So you see more and more aortic sclerosis and calcification and aortic stenosis, which is tightening of this vessel right here. And the question I have is did I do that right? Is that the right one?
I think it's probably around this time.
All right.
Yep.
Yep. So the question I have is, there's new surgery, right? They're doing this without having to open the heart like we just saw. How is that going? what is the statistics on the success rate and the risks of that procedure?
That is a new procedure that is just coming out, and if you hear of it, it's called TAVR, T-A-V-R, for a percutaneous aortic valve replacement is what that basically stands for.
So you don't have to crack the chest, you can do it right like you're doing an angiogram.
Right, and we get a ton of questions about that, but that is for a very small fragment of the enormous number of people that need to have their valve replaced. It's a newer technology, it's coming out, and with most new things, you find out the pitfalls and the drawbacks, and you also make discoveries about things to advance it to be better for the future. And I think that it's very exciting, and there are some very good things about it. On the other hand, the case selection is crucial for that procedure.
Right. There's a risk of stroke with that that's higher than with the other surgery.
A very high risk of, when I say risk of stroke, it depends on how hard you look. If you use some of these sophisticated scanners, you can see evidence of issues in many people. It turns out that the significant strokes is a far smaller group, but you have to remember these are people with very old pipes or very old arteries, and it's like if you've ever cut open an old pipe in a house, you see that chalky calcific stuff in there. That is the stuff we worry about breaking loose and causing those strokes.
Great. Okay, stress echocardiogram, nuclear stress test, is it a good test, and when should someone have it? So a stress echocardiogram and/or a nuclear stress test. Those are tests to look at coronary disease. When should it be done?
The thing is that I think we do way too many tests in cardiology these days and not enough emphasis on what you should do the other 364 days of the year. And if I try to get people to exercise, just like we were talking about earlier between the break there, Rick, and the thing is if you are at your ideal body weight, you exercise regularly, you don't smoke, you take care of your blood sugar if you have diabetes, and you walk 2 or 3 miles a day or ride your bike 2 or 3 miles a day, the doctor can tell from talking to you whether you have issues or not. The other problem with stress tests is that you can have 70% blockage in all 3 of your arteries and go 100% on that stress test and be given the false idea that you don't have any problems when the test will come out normal. You think,
I'm healthy.
I'm healthy. But look in the mirror, that's where you can tell if you're healthy or not.
Yeah, I think that's like all tests in medicine, that sometimes there's like PSAs for prostate cancer. They can be abnormal when there's nothing wrong, and they can be really normal when there's something bad. And so when a test is not as good as it should be, we can't be dependent on it. We can use it, but there's a time to use it.
So there's definitely a time to do those tests. I'm not saying they're not good, but I think we get seduced by all this technology and these things when we should live a healthy lifestyle the whole year.
Here's someone from Sioux Falls who suffers from periods of a few minutes to all day of very irregular heartbeat and then chest pain in the mid-sternum, not into the arms. Should I see a doctor? Riyad?
Well, absolutely. I mean, all those are red flags. So it could be normal, abnormal. It's hard to say, but just given this presentation, it would be worthwhile seeing your doctor right away and just figuring out what's going on.
Right. Mitchell, sleep apnea, atrial fib, relationship between them.
I'm sorry.
Sleep apnea.
Sleep apnea, very, very strong relationship between sleep apnea and atrial fibrillation. More and more studies nowadays emphasize the need to investigate for sleep apnea if you have atrial fibrillation as a presentation.
Right.
A lot of snoring men and occasionally women that need to investigate that problem.
Well, I mean, the danger of sleep apnea, I mean, they get is fast aging. They get coronary artery disease. They get atrial fib. They get hypoxia. They get, I mean, it's a bad, bad thing. And if you can be tested for that, I mean, if you're snoring and apneic at all, get off to a sleep study and be studied.
I don't know what the pulmonologist would say about this, but to me, it seems like there's an epidemic of sleep apnea. I mean, I see it in so many people, and many people that don't even think to get it checked for.
The best way to improve your heart health is not to diet for a few weeks or months with some fad diet. You're faithful for a while, but you just can't maintain it. But rather to find a way of eating and choosing your meals that can change the rhythm of your life for the rest of your life.
There are 2 diets that are currently recommended for treatment of heart disease: the Mediterranean diet and the TLC diet, better known as the Therapeutic Lifestyle Changes diet. These 2 diets have many similarities, and some of them include: choose your oils wisely. Make sure when you choose your oils, you try to limit your saturated and trans fats. These two fats are found in prepackaged foods and also in many animal products. Choose omega-3 fats, monounsaturated fats, and polyunsaturated fats more often. These are going to be found in healthy oils such as olive oil, canola oil, nuts, seeds, and other similar foods. Try to make sure you consume fish twice a week for the heart health benefits of the omega-3 fats. Add plenty of fiber to your diet by getting fresh fruits and vegetables and also whole grains. And again, make sure you're looking for the whole grain or whole wheat on the packaging. Slightly limit your sodium. It is recommended that you cut back on your sodium a little bit. Just sprinkle salt on your food to taste. And also get plenty of exercise. The Mediterranean diet also recommends small amounts of red wine if your doctor is okay with that.
We've got a bunch of questions. We want to dive right in. Here's a 90-year-old person who called in and said, whole family has died from heart disease. Am I just lucky, or is there still a chance at 90 to develop heart disease?
At the age of 90, this man definitely has heart disease. Statistically in the United States, you hear of people getting these calcium scores. 100% of the men in the United States over age 70 have calcium in their arteries. So it's not do you have it or don't you, it's what did you do to minimize your risk. So we all have it. When you look at that graphic that you showed earlier in the program that has that huge pie with all of the deaths in the U.S. from heart disease, most common thing that kills people, statistically 1 out of 3 women going to die of vascular death. In fact, we're in February where they have the Go Red for Women to make women aware that heart disease is their main risk. Everybody has it, so you have to live every day like it depends on it.
Yeah.
You know, that you can't take your life for granted.
That's a good one. Did you hear that one? So we've talked a lot about it in a very quick way. I've got a bunch of questions about lifestyle. What would be the ideal lifestyle, Riyad, for heart rhythm or atrial fib or coronary disease or heart failure? What would be the lifestyle that you would recommend?
Well, obviously it depends on what you have. As a patient, if you are in heart failure, you are limited as far as your ability to do things like you used to do before, but you still daily or regular exercising of some sort. I mean, you don't have to break sweat with this, but at least even regular walking, but do it on routine basis every day. That would help.
I love what he said, every day. Did you hear that? Every single day. That's the key. You need to do some exercise every day.
You know, Rick, I hear this all the time, and I have people come to me and say, well, I haven't been out because it's been the cold weather, it's too hot, too humid, too dark, too light. Yeah. And then I ask people, are you going to use your heart today? And if the answer is yes, then maybe you should do some maintenance to try to keep the thing healthy so it lasts your whole life. It has to last 100 years. Think of any machinery that you would turn on and it would go for 100 years with no maintenance, no downtime, no greasing the circs, no changing the oil.
Maintenance.
Maintenance.
Riyad, you were about to jump into a diet.
Well, as far as diet, obviously now a lot of interest in the Mediterranean diet. And that is absolutely helpful to think about the kind of food you eat. So a healthy diet goes without saying. We all know what it is. It's just that if we have the will to do it.
And the other issue is if you can eat too much of anything. The great oxidative load is too much food. So even that perfect Mediterranean diet, we would sure like to have it done in limited amounts. Brookings, is there a surgical procedure on the horizon for atrial fib? A surgical procedure?
Well, indeed, surgical procedure. Actually, the first attempts for dealing with atrial fibrillation or curing it was surgery. And then the catheter came in later on to try to do a similar way of doing it. Success rate, as a matter of fact, with open chest surgery is higher than the usual one with catheter. So it is available, but it is kind of more aggressive approach to dealing with atrial fibrillation.
So there's two pathways that I see. One pathway is to control the heart rate with diltiazem or one of the drugs that slows the heart rate down, DIG. I don't use it much anymore. I just ordered one dose a patient for, haven't done it for years. Slow the heart rate down, still in atrial fib, anticoagulate with warfarin or one of the drugs, and live with it. The other option is to try to get them back to a normal rhythm by shocking them after you've anticoagulated them for 2 weeks. Hold it down with the right drug, which will work 50% of the time, and then you still keep them anticoagulated, but you may not need that diltiazem or that slowing rate, but then sometimes you do. I mean, and then the question is, all this fussing over here with the defibrillator and so on, and this other drugs, is it better than just rate control with anticoagulation?
Well, it depends, and there are two approaches to dealing with atrial fibrillation, obviously. One of them is the strategy to try to control their heart rate, and those are the individuals who you have tried to get them back to regular rhythm, but you couldn't, or they have no sensation of that irregular rhythm. The other part of the other type of patients are the ones who really feel it, and they are upset and uptight about having that irregular rhythm. They cannot tolerate it. They cannot live with it. Some of them cannot tolerate it for a day or two, and some of them just after a while they become annoyed by it. So you have to tailor your treatment accordingly. There's no one size fits all.
And when you're in atrial fib, you have 10% less ejection fraction so that you can feel that you're weaker. If I had atrial fib, I would try your way for a while. And if I just couldn't stay into it, I'd say, okay, enough.
Here we go.
You're going to take any comment?
Yeah, the one thing that I would caution people about is that if your neighbor has atrial fib and the guy down the block has atrial fib, one size does not fit all, even these two. And saying you have atrial fib is like saying you have a vehicle. It doesn't tell them whether it's a sport utility or a cement mixer or a 18-wheeler or a pickup
or
Chevy or Ford or Prius. So there's so many varieties of atrial fib. In general, they come into these two categories that you two gentlemen have been talking about. But it's much more complicated than that in any individual case.
We've got a caller that says AV nodal reentry tachycardia. Has the technology changed now so there's something that we can be done? Riyad, very quickly, AV nodal reentry tachycardia, PAT, right?
PAT. Well, this is a specific kind of tachycardia that happens in the top chamber of the heart. And it's related basically to an extra connection that a person is born with. And we do deal with this with the ablation procedure. So this has been around for a long time, and we deal with it and we cure it nowadays, either by using what we call radiofrequency ablation, which is heat, or using the freezing. The freezing.
Oh yeah, now you freeze. So I had a patient in her 80s, and she would, and it was happening more nowadays. Her heart would take off at 180 per minute. It would really scare her. It was uncomfortable. She'd get chest pain when it happened, and then she'd come to the emergency room. They'd give her a drug, and it'd be back to normal. And this started happening more than once a year, then once a month, and then it's once every 2 weeks. And I sent her to you, and you buzzed that little part of reentry, and it normalized. And she hasn't had one more spell. I mean, it was a wonderful cure. And so those are the examples that can happen with those kind of ablation things. Thank you for that.
You bet.
Have blood pressure of 138/108. Explain why diastolic is so high no matter what I take. Diastolic, systolic, how high is high? What's the right answer, Mike?
There's a lot of controversy in the management of blood pressure. And as you know, the society just came out with some new guidelines. Now, I am old enough and have enough gray fur to know that the guidelines they used to have are not the guidelines that they had then, and then now they're coming out with new guidelines. The thing is talk to your doctor about your specific case and what constitutes the high blood pressure and a narrow pulse pressure and why the blood pressure is low. 92 million people in the USA have high blood pressure, and there's a jillion drugs to take care of it. But when you think of it, you're going to take these drugs, whatever they are, if you really have high blood pressure, for maybe 30 or 40 years. So they got to work, they can't cause side effects, and you have to be able to afford them.
Yeah.
And so if the Lord intended all these drugs to be in the soup, he would have put them in at the beginning.
Yeah. I have to say that even the people who were the experts couldn't agree this last time, and they had to split. There was great controversy among the experts who were saying it was so good. I know that in the elderly, right now they're saying 150, maybe even 160 is okay. I think the diastolics is less and less important, and my sense is that it does depend, just like we've said, how many times have we said this tonight? Upon the individual.
Not only this, added to this, one thing about diagnosing hypertension is that I tell all my patients that before we say that I do have high blood pressure or not, check your blood pressure 3 times a day for about a week or 2 to make sure that this is indeed what your pressure is. Yeah. And check it always whenever you're resting or when you're angry, so it does not get affected by the weight.
The other thing I want to get in here too is I have a significant disagreement with the people allowing these blood pressures to be in the 150s and 160s. For the following reason: if you think of that machinery that's beating 100,000 times a day, to have the higher blood pressure on there, it's like any piece of machinery. It's common sense to think that the lower pressure that it's going to operate on is better, as long as it's not too low. Your mortality goes up for every millimeter your blood pressure is over 110. So even if you're 130 to 140, there's an increased risk, and the main risk is stroke, not a heart attack. And so you want to keep your blood pressure as low as possible to minimize the wear and tear on all of your body's machinery.
So, but I beg to differ in one sense. In some elderly people, who they come into me, they have 160, 170 systolic, and yet they have 110s, they have 106s. They pass out when they get up to go to the bathroom, and I look at the balance of it, and they're in that age bracket where their pipes are stiff.
But I'm glad you brought that up too, because that is exactly what Riyad is talking about. So if you've had high blood pressure over the years, 100,000 times a day, that's hammering away on those pipes. They get stiff. And so if I come to your house and tell you there's water in your basement, your blood pressure is going to go up. Mine will go up too, but it might not go up as much as somebody who's had high blood pressure many years. And so that's why you hear these people coming in, they're up in years of ways, and they say, nobody can control my blood pressure. It's 180 1 minute, and like you said, 120. So you have to take a diary, like Riyad was saying, and average them out to see where is the sweet spot to be in the right range most of the time.
But you don't want to drop them out and have them break a hip because you're controlling their blood pressure. So there's a balance too. If you had aortic valve sclerosis, how would pregnancy affect the escalation of sclerosis? Sclerosis is calcification, hardening of that valve.
Yeah, most people in the fertile years don't have problems with aortic sclerosis because they simply haven't used their valve long enough to get that. So that must be somebody that's at the end of their fertile years to have aortic sclerosis, or they may have a congenitally abnormal valve that took too much wear and tear, and that might be a specific issue. So they should be checked out for some congenital issues if they're still fertile with that problem.
All right. 20 years ago, I had bypass surgery. If it fails, can they do it? In other words, can we redo a 20-year-old bypass?
The main reason for needing to redo bypass is because a lot of people don't change their ways after they have the first operation. They go back to their life just like they used to be. They think, I was down to Sioux Falls, that heart surgeon put in those new bypasses, now I can go back and eat the Cheetos and the potato chips and everything else they can think of. And now this person did a pretty good job, 20 years
20
on
years?
those. Yeah,
the average is 7 or 8, isn't it?
7 to 10 years, 1 out of 5 chance of needing a repeat bypass operation. So that person did very well.
From Britain.
Yep, and we have very good things. Now, that person probably had their bypass when they were 50, so maybe they're 70 or 75 now. And so, in those age range, maybe we want to try harder at fixing things through the legs or with medication, or the arm or the wrist or something like that.
From Mobridge, is it uncommon to hear your heartbeat in the middle of the night when you wake up? Is it uncommon?
Well, I mean, it depends on what you mean exactly by this. Sometimes under stress, or if you have a lack of sleep, or if you have taken some kind of stimulants or even excess coffee, a person can hear their own heart beating when they are laying down sleep at night. Now, if you got up and you feel like your heart is racing, I'm not sure if that necessarily is an abnormality by itself.
Okay. Vegan diet helpful in reversing heart disease?
Yes, it can be. The diet, it can be extreme, though, and you want to make sure not to exclude nutrients. A famous example of that is Bill Clinton. A lot of people remember when he had his bypass operation, 3-4 months later, a couple of stints, 3-4 months later, a couple more stints, and then Chelsea, his daughter, was worried that he wouldn't be alive for the wedding. And he got going with a dietitian from the Cleveland Clinic, and now he's a vegan. And when you see President Clinton on TV, or former President Clinton, I should say, he is a very slim character, and now he has not had any issues with his heart since then.
All right. Well, we'll be back right after this.
Roy, is that smoke?
Oh, that? It's just a little fire. No biggie.
Aren't you going to do something?
Nah, I'm gonna wait a bit, see what happens.
Roy, your house is on fire. Dial 911.
I don't want to bother anyone. It'll just cause a big commotion.
I have to get some help.
Ignoring the signs of a heart attack would be just as ridiculous. If you experience chest pain, call 911 immediately and seek help.
He was a perfect specimen of health, physically fit in his mid-50s because his work and all his hunting and fishing involved a significant amount of physical activity. But this early morning, he woke with an uncomfortable chest pressure going into his neck and jaw. He arose to find no relief with stretching, a glass of milk, or anything. Finally, after arousing his wife, they made their way to an emergency room where he was given a merciful pain relief and immediately tested to find if it was his heart that was causing the pain. Not long after arriving, awaiting the test results, and as his wife was talking with him, he suddenly slipped into unconsciousness. It was there on that cold midwinter South Dakota pre-dawn hour that he died, despite all the best resuscitation efforts of the emergency room team. Likely due to an arterial blockage and an irritable heart muscle, the symmetry of his heart rhythm had changed into one of pure chaos that wasn't effectively pumping blood, and he just wouldn't be converted back to normal again despite every effort. The value of rhythm is never more evident than during a cardiac arrest. The definition of rhythm comes from Greek roots of rhythmos, to flow, and rhyme, meaning any regular, recurring, pulsing, a succession of contrasting elements occurring over various periods of time. Think of the rhythmic experience from some speech and verse, rhyme and song, drum and dance. There's something about rhythm that calls for symmetry. And when it's out of sync, there is a part of us that becomes uncomfortable, and we're left wanting to make it right again. It is interesting that the rhythm of walking, running gait, of breaking waves on beach, or of heartbeat pulse all match common musical rhythms of the Beach Boys, Beatles, Blake Shelton, Beyonce, B.B. King, Simon and Garfunkel, Smokey Robinson, Stan Getz, The Supremes, Taylor Swift, and Benny Goodman. You pick the musical style and that life-sustaining beat is there. The rhythm of life is regular, recurring, pulsing, a succession of elements over time, like the flow of seawater, fish, and animals with ocean meeting shore on an estuarial tide. The seasonal swim of salmon up a freshwater river looking for a place to spawn. The birth of lambs and calves bursting forth on an early springtime prairie pasture or protected manger. Or even the 80 to 90 year life cycle search of humans moving with joy, sorrow, and grace from birth to natural death. So when a man dies too early, the rhythm is disturbed, the symmetry is out of sync, and we're left wanting to make it right again. So we've got a bunch of questions, and we're going to be answering them after the show, and you put it on the internet. But let's do so I've got 15 seconds. Do you have we've got to go. This brings us to the end of our show. Thank you, our guests, Dr. Riyad Mohama, Dr. Michael Hibbard, for helping us to answer your questions from our viewers this evening. As it often happens, we don't get to answer your questions, so go to our net site, oncalltelevision.com. So, from somebody who knows a thing or two about rhythm, Elvis Presley said, rhythm is something you either have or you don't have, but when you have it all over. Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
LARSON Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, Brookings Health Systems, Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communication. Closed captioning for On Call is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.